de Quebec, and I'm very, very happy to have you here for this série estivale d'apprentissage virtuel. I'm always proud of the work that we do in Quebec, very innovative, very interesting, so very happy we can take this to a larger audience. I'm going to explain to you a little bit about how the webinar works. I will then have a land acknowledgement, and then I will turn it over to Yves Courtourier, who is the Executive Director for Réseau 1, and he will make an introduction, and then we will start with the panelists. So you are joining Zoom webinar, which means we can't see you and we can't hear you. You're on mute. So you have two ways to communicate with us. One is the chat screen, which is on the bottom. It's a single call out screen. If you click on that, you have two options. You can send a comment just to the panelists, or you can send a comment to all attendees. Si ça c'est quelque chose général et pas une question, ni dans le chat. So put it in the chat if it's just a general comment. If you have a question you would like the panelists to answer after their presentations, there is another additional button on the bottom called Q&A. If you click on that, ça c'est la place pour mis les questions. If you put the question as anonymous, I will not read out your name. If you leave your name, I will read your name when I read the question to the panelists. None of the other attendees can see this question, only the panelists, and I'll be reading them out loud en français ou en anglais. I will probably do a slight translation to put them in both languages for our audience members. So that's how a webinar works. What I'm going to do right now is I am going to read a land acknowledgement, a virtual land acknowledgement that was prepared by the College of Family Physicians of Canada. And then I'm going to turn this over to our speakers for today. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. We recognize that the many injustices experienced by the Indigenous people of what we now call Canada and Quebec continue to affect their health and well-being. We respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all attendees to reflect on the territories you're calling in from as we commit ourselves to gaining knowledge, forging new and culturally safe relationships, and contributing to reconciliation. So with that, je suis très hâte de voir qu'est-ce qu'on va attendre aujourd'hui. So Yves, I'm going to ask all my speakers to turn on their videos for a second and just sort of do a wave hello. We've got quite the panel. And I will ask Yves to share his screen. And if you want to see everybody, you can either look at speaker view or you can click on the top for gallery view. So Yves is now going to turn on unmute. Yves, est-ce que vous êtes prêt? I don't hear Yves. Okay. Yves, can you say something so I make sure we've got your volume on? Okay, we'll just, obviously we're just having a few, it's one of those mornings, last seminar of this series, it's summer, beautiful day outside, so I hope it's a beautiful day across the country. Yves?
Est-ce que vous m'entendez?
Oui, on entendait. La vue pour le diapo, c'est encore pas tout le diapo. It's not on slideshow.
Est-ce que vous voyez le diapo? La diapo?
Oui, mais it's not the slideshow yet. It's all the slides are on the side, the main one. Mais vas-y quand même, je pense que tout le monde peut voir ça.
Alors, je suis un peu désolé pour le cafouillage. Ça ne fonctionne pas comme je l'espérais. Alors, voici. Je crois que ça y est. Alors, désolé vraiment pour ce cafouillage-là. Donc, je m'appelle Yves Couturier. Je suis le directeur scientifique du réseau 1 que je dirige avec Catherine Hudon. Nous sommes tous les deux de l'Université de Sherbrooke et nous avons beaucoup de plaisir à animer ce réseau-là qui est très dynamique. On va aujourd'hui vous faire un portrait d'un certain nombre d'initiatives qui se déroulent au Québec liées à la COVID. Il y a d'autres choses qui se passent au Québec, mais on a fait un choix de vous présenter quelques-unes de ces initiatives-là. Donc, il y aura beaucoup de personnes qui vont parler à tour de rôle, mais il y aura tout de même une paire de questions ouvertes à tout le monde par la suite. Le réseau Québec s'est beaucoup mobilisé depuis mars dernier pour faire en sorte que la première ligne soit considérée, soit au centre des préoccupations publiques en matière d'adaptation du Québec à la COVID. Vous savez que le Québec est toutes les provinces, c'est la province la plus touchée au Canada dans cette matière. Donc, on a fait beaucoup d'efforts, notamment 3 appels à projets distincts qui ont financé 5 projets, dont certains seront présentés aujourd'hui. Des projets cofinancés avec d'autres partenaires, d'autres réseaux québécois. Et nous avons soutenu aussi 2 projets ancrés dans les rappels avec notre partenaire très privilégié qui est l'unité SRAP du Québec, l'unité de soutien SRAP du Québec. On a la chance au Québec d'avoir une collaboration très étroite avec ce partenaire-là. On a aussi mené un scan des innovations et des besoins en première ligne dès le mois d'avril et pour les mois qui ont suivi. Il y aura une présentation détaillée de ces premiers résultats liés à cette activité-là. On a fait aussi, on a soutenu le développement d'une veille des essais cliniques pragmatiques autour de la COVID pour le Québec, de façon à faciliter l'adhésion des cliniciens qui voudraient s'engager dans une recherche clinique COVID, mais qui sont peut-être submergés par un foisonnement d'informations. Nous avons aussi fait un effort très important de partage de ressources à nos membres. Donc, le Réseau 1 Québec, c'est plus de 900 membres aujourd'hui. Donc, des ressources qu'on a partagées, des ressources COVID qu'on a partagées. On a aussi publié un certain nombre de réflexions. On peut déjà vous dire qu'au Québec, du point de vue des décideurs publics, disons que la place de la première ligne s'est avérée moins centrale qu'on ne l'espérait. Et donc, on a voulu produire des textes de réflexion. Il y en aura d'autres de publiés en septembre pour prendre de la hauteur. Qu'est-ce qu'on peut faire pour s'adapter au Québec à une éventuelle deuxième vague de COVID? Nous avons collaboré à diffuser le sondage destiné aux cliniciens diffusé par le réseau Pékin. On le fait avec beaucoup d'intérêt, notamment en termes de traduction. Et nous avons aussi diffusé, avec notre partenaire qui est l'unité soutien SRAP du Québec, 4 vidéos pour faire en sorte de valoriser le point de vue des patients partenaires dans un contexte d'urgence comme la COVID actuellement. Donc, je retourne la parole à Gillian Bartlett qui va s'assurer de la traduction, de la coordination, du respect du temps de présentation pour chacun. Donc, je retourne la parole.
Merci, Yves. Thank you very much. As Yves said, we're going to do a fast roundtable of all the exciting stuff happening in Quebec. So our first speaker, I will ask Simone to turn on his video and share his screen. For those of you attending where your high school French may be failing you a little bit, the slides are in English, and if you have any questions, you can message me or any of the panelists if you want a specific follow-up. Okay, Simone, vas-y. Est-ce que c'est possible pour vous? Can you make it the big diapo?
Yeah, I'm trying because I have the same issue than Yves right now, so I'm just going to try to do it. Yeah.
Oh, voila! It works.
Yeah, but I don't see my text now. That's the problem.
Oh, don't you?
I'm trying. Just give me a second.
This is better than the technical issues I had for our very first one, where I was a speaker and my Wi-Fi quit. So I called in, no idea if anybody could hear me, no idea what they were seeing on the screen. So this is not quite so bad. Can you, you can do it just like that,
yeah, I'm
Simone,
just
you
going
can do
to
it just
put
like
it
that.
like this. Yeah, so
Perfect.
we have enough space. Sorry
Okay,
for that.
vas-y.
So thank you very much for allowing us to present the results of our COVID-19 primary care initiative. So my name is Simon Descaries. I'm a postdoctoral fellow in primary care and physiotherapy at University Laval in Quebec, and next year a faculty at University of Sherbrooke. So today I represent our knowledge translation team from Réseau 1 Quebec, who have been working on this COVID-19 initiative, including student Melanie Ann Smithman and Amira Benzina, our summer student, who did tremendous work on this initiative. So COVID-19 pandemic hit Canada in March 2020, and rapidly Quebec became the most affected province in Canada, followed by Ontario. As of today, we had over 58,000 cases and 5,500 deaths, about half of all Canada. Early on in the pandemic, our government massively invested resources in hospital-based settings to prevent death, rightly so. However, the needs of primary care, where most care happened, was and is still unaddressed. And last week, our government published the document to prepare for the second wave, and primary care was absent from all the document. So as a network representing all primary care and community-based care, we decided to take the matter in our hand. So, So we established a COVID-19 primary care committee on March 30th. The committee's objectives were to observe the needs and innovations that emerge from primary care and community-based practices in the context of COVID-19, and two, to disseminate the reported needs and innovation with other primary care practices across the province of Quebec. We created a questionnaire that allowed members of our networks to share needs and innovations concerning the transformation primary care is facing. We sent the questionnaire using a WAVE format to allow continuous monitoring and sharing of what was happening in primary care. I'm now sharing some of the results and lessons we learned over the last 6 months. So for the participant characteristic, we had 98 members that shared with us all their needs and innovation that were happening in their clinical settings. Participants came from 13 out of possible 17 administrative regions in Quebec, with a third from Montreal, our largest and most hit city during the pandemic. Participants came from 7 different primary care settings, and most were family physician and researcher. And luckily, we also had 5 patient partners who shared with us their view of the pandemic. If we look at some of the results of our initiative, so first what we did was classify emerging needs and innovation in different teams. Overall, the 3 most common themes for emerging needs were to ensure access to services, for example, primary care follow-up for COVID-19 patients, 2, to maintain well-being of patients, so innovation that concern, for example, community resources for elderly, and 3, to control the disease spread in primary care. The 3 most common innovations themes were service reorganization. So for example, adding rehabilitation to primary care for COVID-19 patients, teleconsultation, and 3, community health. So innovation focusing, for example, on the collaboration between community organizations to ensure food security. What's important is that we found more than 12 themes for needs and innovation, and are currently still working on this to really identify the scope of the needs. This demonstrates that primary care needs go far beyond only 1 or 2 categories. Next, we also collected from respondents the unanswered needs and currently neglected population. So in view of our members' access to services in primary care, clear guidelines concerning management during COVID-19, and improving management and administration remains limited. Also, patients with chronic diseases, elderly and population with socioeconomic difficulties remains neglected during the pandemic. Our knowledge translation strategy included the continuous dissemination of our observations. We designed 2 infographics that you can see here, and a third one on the deconfinement period is coming soon. So we share these infographic and engage our community via social media. That allow us to identify 12 of our respondents that provided in-depth knowledge via a semi-structured interview to describe their primary care initiative. So this is what we're working right now to see if there are innovations that we could scale up across primary care in Quebec. So as a conclusion, as a network, we engage our primary care community at the provincial level. Our members were very kind and share close to 100 needs and innovation facing primary care now and in the wake of a second wave. Needs and innovations span across a wide diversity of teams, reflecting the complex reorganization we are facing in primary care. And we continue to leverage our community's collective mind to ensure primary care is giving appropriate attention and funding now and beyond COVID-19. Thank you very much.
Merci beaucoup, Simon. C'est très intéressant. Et félicitations for your appointment coming up. That's great news. That's a little less stressful to finish your postdoc, knowing you've got and Sherbrooke is a wonderful town and university. So félicitations. OK, prochainement, Eric, est-ce que vous êtes là et prêt pour faire votre présentation?
Yes, I would like just to share my screen. Okay. Sorry.
No problem.
Is it okay?
Yes, perfect, parfait.
Let me just, give me just a couple minutes. I will just want to change a little bit my place here because a lot of noise there. Give me just 1 second.
Yeah, no problem. Eric, est-ce que vous voulez qu'on va aller à quelqu'un d'autre et puis on va revenir pour toi?
No, it's okay. I would like just to change the place. It's okay. Don't worry for that. Just give me a second, please.
Okay, well, I wanted to thank everybody again for coming today. We've got very, very good turnout. We have over 85 participants, and given that it is a stunning day, and I think all of us are feeling that summer might end a bit sooner than we were prepared for, I appreciate you spending the time in front of your computers listening to this update.
Is it okay now?
Yeah, and Eric's outside, yes.
Yes, I just changed the place because when we work at home, it's not easy at all.
No, it is not. It is not. That's why I've got a weird background. I won't even tell you what's going on in my house right now. Okay, Eric.
Okay, good. Thank you very much. So thank you very much to give me this opportunity to present my research. The title of this research, The Validation and Testing, a Guide to Measuring the Cost Associated with the Management of COVID-19 in Long-Term Care Facilities. Before going to the little presentation I'm going to do, I would like just to present the people I work with. It's, we have Roxanne Borges da Silva, which the core PI of my research, of this research, and also Kelly Kilpatrick, Drissa Sia, Idrissa, and Josiane, Sandra, and Stephanie. And this research was founded by the B-Réseau financing, Réseau 1 Québec, and RISIC. So I would like to thank first these founders. We decided to conduct the research in long-term care facilities because you know that in Quebec is the first province of the Canada affected by COVID-19. And we have a lot of more than 5,000 of people the death by COVID-19 in Quebec. And especially for people who are aged more than 17, we have around 92% of people, the death related to the COVID-19 in Quebec is those for these people. And more than 100 long-term care facilities are affected for this problem. So it's the main issue, the impact of COVID-19 in long-term care facilities in Quebec. So the need for the research, we would like just to, first of all, the goal of we like just to assess the socioeconomic impact of COVID-19, of this pandemic, in seniors living environment and also in long-term care facilities. But before conduct and going to this large research, we just want first to develop and validate and test a guide to measure for the measuring of the costs associated to the COVID-19, the management of COVID-19 in Quebec. Because before assess to the economic or the assessment of socioeconomic assessment of the impact of COVID-19, you have just to have a guide and also I can say a question or a tool to measure the costs related for this management of COVID-19, especially in long-term care facilities. So this research want to develop and validate and also test this guide. So I would like just to present the methodology because we are just funding. So I don't have any result to present you now. The management of referring to Findler's, the management of disease or the management of quality of security of patient, to measure the cost of the managing we have to measure first of all the cost of investment in prevention associated to the clinical best facilities associated to the prevention of infection, prevention and control of infection, prevention and control of COVID-19. And second, you have to assess and to evaluate the cause of diseases and also the quality of life and death related to this this problem. So we decided to merge two guides because we built two guides to the management of nosocomial infection, especially in acute care facility. And we would like just in this research to adapt this guide in long-term care facilities. So these guys will be divided in two parts. First of all, we have the first part of the guide which help us to measure the human resources and material use in clinical best facilities. And we have also the second part of the guide, we're going to help us to measure the patient chart, all things related to the diseases or to taking care of the people affected for this problem. And we add also one section related to the quality of life and death and the estimation, also the quality of life of these people, of this resident in long-term care facility during the period of COVID-19 pandemic until now, since the start of the COVID-19 pandemic. So as you see the timeline, this project is going to from June 2020 to March 2022. So I hope we're able to build a guide And also, we would like just to validate this guide by Delphi approach with experts to adapt the validation of the content of this guide in long-term care facilities. So because now, as I said, we have this guide especially for acute care, and we said we would like just to validate and to adapt this guide to long-term care facilities, especially for the problem of COVID-19. After this, the validation, we are going to pilot these tools in a cross-sectional study in 2 long-term care facilities in Quebec. So the research now is just doing in Quebec because it's a pilot study. And after that, we decided to pilot this long-term, this guide or this tool in 1 long-term care facilities which will not affected with COVID-19, and other healthcare facilities which affected. We have more than 20 cases of COVID-19 in their healthcare facilities. And for doing that, we're going to use patient and administrative data, and we're going to compare the information related to the investment in prevention, also the cause of infection 1 year before the COVID-19 and 1 year since the start of this pandemic. So we are going to know very well the repercussion or the impact, and to compare just the impact of the change we have in the cost of the managing the COVID-19 or the managing infection of COVID-19 after and before and after since the start of the COVID-19 pandemic. So as I said, the main issue, the main objective of this research are to adapt the content of the 2 guides or tools to merge it in one. We are going to call it now the coût-geste. Coût-geste is just the coût de gestion des infections de la COVID-19 dans les CHSLD. And we are going also to pilot this guide into long-term care facilities, as I said. So the expected outcome is just to develop this guide and also provide a real help and give information about the cost, and also to inform our decision makers and also our healthcare provider to the impact of the change we have in the cost of the managing the COVID-19 before and since we started, since the problem of this pandemic. Okay, so thank you very much. It's just going to, I'm done.
Merci, Eric. And I do want to make a special thank you to my Quebec colleagues for doing their best to make this a bilingual session. C'est grandement apprécié. Okay, our next speaker is Nancy. Nancy, est-ce que...
Oui, je suis là.
Oui,
Oui,
vous êtes là,
voilà.
vous êtes prêts?
Je vais tenter de partager mon écran.
OK.
Voilà. Oups. Est-ce que ça fonctionne?
Ça commence à fonctionner, c'est juste pas encore...
Oups. On dirait que ça... Bon, alors là, je vais essayer de... Bon. Je ne sais pas trop quoi faire. On dirait que c'est pas vraiment l'écran principal.
Oh, ça, c'est toujours un problème avec quand il y a...
Attendez un petit peu. Je vais essayer de recommencer. Share screen 2, c'est celle-ci. Si je fais share. Vous ne voyez pas mon PowerPoint, hein?
On voyait le PowerPoint, c'est juste que ça, c'est encore comme, it's not a slideshow yet.
OK, bon, je vais faire
on voyait certainement.
diaporama à partir du début. Là, est-ce que
Oui,
ça va?
c'est parfait, c'est parfait.
C'est
Vas-y.
parfait comme ça, donc je peux y aller.
Oui.
Bon, alors bonjour, je suis Nancy Côté, je suis professeure au département de sociologie de l'Université Laval. Je suis aussi chercheure au VITAM, qui est le Centre de recherche en santé durable, qui est associé au CIUS de la capitale nationale, et je suis co-leader de l'axe environnement, milieu de travail et milieu de vie. Donc, le projet dont je vais vous parler aujourd'hui s'intitule « Apprendre de la COVID-19 », projet exploratoire en GMFU visant l'implantation de pratiques novatrices en première ligne. I will make my presentation in French, but feel free to ask me your questions in English if you want. Alors, donc, toute une équipe de recherche qui est mobilisée dans ce projet-là. D'abord, nos partenaires en première ligne, donc des partenaires qui sont des gestionnaires, des cliniciens, des professionnels du CIUS de la capitale nationale, mais aussi des médecins qui sont impliqués sur le projet. On a aussi un usager partenaire qui est M. Michel Leclerc et on a aussi toute une équipe là, de recherche composée de plusieurs chercheurs de différentes universités, donc Jean-Louis Denis de l'Université de Montréal, mon collègue Andrew Freeman qui ne pouvait pas présenter avec moi, mais qui va se joindre à nous un petit peu plus tard au courant du webinaire, qui est de l'Université Laval, Marie-Pierre Gagnon de l'Université Laval également et Emmanuel Jean. C'est important de dire là, que ce projet-là est mené vraiment en étroite collaboration avec nos partenaires et qu'à certaines phases du projet, ce sont même les partenaires là, qui sont en leadership. Donc, le projet poursuit en fait, je vous dirais, deux grands objectifs. Un premier objectif qui est en période de COVID-19, d'identifier les bonnes pratiques en GMF et en GMFU pouvant être pérennisées et transférées dans d'autres milieux cliniques. Et comme deuxième objectif, c'est d'implanter certaines de ces pratiques-là dans un GMFU pilote et de les évaluer. Donc ici, on s'intéresse aux pratiques qui possèdent un potentiel de pérennisation pour faire face à une éventuelle deuxième vague, mais aussi pour une transformation à plus long terme de l'organisation des soins et des services en première ligne. Et par pratique clinique et organisationnelle, on a une conception quand même très large. On s'intéresse autant à tout ce qui concerne les pratiques qui visent à l'optimisation du travail d'équipe, les différents modes de leadership, le recours au numérique en santé et toute autre pratique pertinente. En ce qui concerne nos méthodes et l'échéancier, donc c'est un projet là, qui comporte 4 phases. Une première phase qui est terminée, qui a consisté à la recension des pratiques cliniques et des innovations auprès des chefs psychosociaux du CIUS de la capitale nationale, donc les chefs psychosociaux qui ont une vision assez globale de ce qui se passe dans les cliniques. Ensuite, en phase 2, avec nos partenaires, on a identifié les pratiques les plus prometteuses. On a effectué 11 entrevues individuelles en profondeur auprès d'acteurs clés en GMF et GMFU. Et les entrevues visaient en fait à mieux comprendre le contexte d'implantation et le contexte de pérennisation. Donc, cette phase-là est en cours de réalisation. On a pratiquement terminé nos entrevues et on est actuellement en cours d'analyse. La phase 3, qui va se dérouler plus vers la fin septembre, donc on va mettre sur pied un groupe de travail pour identifier les pratiques qui seront implantées dans le GMFU pilote. Donc, comme je vous le disais, ça aura lieu en septembre. Et finalement, la phase 4 qui aura lieu plus tard à la fin de l'automne, hiver 2021, où là, on va vraiment implanter et faire l'évaluation de ces pratiques-là. Donc, je vous présente très sommairement, je vous dirais, là, quelques résultats préliminaires parce que, comme je vous le disais, la phase 2, on est en cours d'analyse actuellement. Donc, on pourrait y revenir un petit peu plus en détail à la période de questions si vous le souhaitez. Mais disons qu'on a identifié 5 grands thèmes qui sont ressortis par rapport aux pratiques innovantes ou aux pratiques prometteuses. Donc, des pratiques qui concernent plus spécifiquement l'optimisation des rôles professionnels. Dans les entrevues, on a beaucoup parlé de l'optimisation du rôle des infirmières cliniciennes, des pharmaciens, mais aussi, étonnamment, des agentes administratives qui semblent être au cœur de toute la réorganisation de la première ligne et souvent on sous-estime un peu leur travail. On a aussi mentionné des pratiques en lien avec l'optimisation du travail d'équipe, donc une meilleure collaboration entre les médecins en GMF, GMFU et les autres professionnels, meilleure utilisation du DME également pour échanger sur les cas cliniques et une meilleure collaboration intra-professionnelle également. On a mentionné aussi des changements dans la culture organisationnelle, donc des rencontres d'équipes plus inclusives et plus fréquentes. Donc, plutôt que d'être uniquement entre médecins en GMF, on inclut les professionnels dans certains cas, pas nécessairement dans toutes les cliniques, mais dans certaines cliniques. Des stratégies proactives pour rejoindre les clientèles plus vulnérables et un certain glissement d'un leadership principalement top-down vers un leadership qui serait plus partagé. Évidemment, toute la question de l'utilisation des technologies, donc consultation téléphonique, téléconsultation également, mais aussi on a relaté l'utilisation de la technologie pour favoriser une meilleure cohésion d'équipe, que ce soit au sein des GMF ou entre les différents professionnels au CIUS de la capitale nationale. Et finalement, être à l'écoute des usagers, donc différentes initiatives qui ont été développées, notamment un pas à pas pour indiquer où consulter, ou encore le développement d'un sondage pour connaître les besoins des patients en temps de pandémie. Donc, des initiatives qui ont été mises sur pied ou qui seront mises prochainement sur pied. Donc, voilà, c'est ce que je voulais vous présenter là, très sommairement par rapport à ce projet-là. Je vous remercie beaucoup. Et là, je vais essayer de me mettre, de quitter. OK, voilà.
Okay, thank you very much, Nancy. I hope everybody can hear me okay. Of course, I'm having internet difficulties because, you know, it's one of those days. Milet, vous êtes prêt pour commencer?
Yeah, are you able to hear me? And I think my slide is already on. Huh? Okay, so.
Yes, you're perfect. Yes, you're perfect. Go ahead.
Great. So I'm happy to present the result of a research that I've been conducting this summer with an amazing team, Marie-Thérèse that is online, Jean-Sébastien, Nadia, and several other great colleagues in different universities in Quebec. So the idea was to do a snapshot of the rapid transition toward telehealth in teaching primary care clinics. So, and it's funded by Réseau 1. So it was quite simple. I'm going to present only the first objective of this broader research project. So today I'm focusing on the first objective that was to do a rapid portrait of this implementation of telehealth. So we invite all teaching universities across Quebec to participate to this research project. And we are really proud and really surprised that almost every clinic have accepted to participate to this research. 48 among 50 response to our survey, and this morning it was nearly 600, so 697% who respond to our survey during summer. And as you're aware, a lot of advice said you should not do survey during summer with clinicians, and you should not do, I guess, survey during pandemic. So it's really impressed that we reach an average of 45 participation. And we work in close collaboration with the 4 PBRN. So we really work hard to have a friendly reminder, a personal to each of those clinics. So I think that show a great result. So I just present you what is the first aim was to have a better understanding what is the change toward telehealth. So that is not surprising, and we can see with other study that after March 15, almost every provider in primary care setting adopt telephone. So the majority of the intervention was made through telephone. And we were a little bit surprised that the video teleconsultation was not really used at the beginning of the pandemic in teaching unit. And an important surprise is also the use of email to communicate with patients, and that has an important increase after March 15. And that is it. What's surprising is that we don't use email before the pandemic as a way to exchange with patients. So that is a great change that we observe during the pandemic. And also that for me was a surprise, because we asked two open questions at the end of our survey, that what is the advantage of using telehealth compared to face-to-face consultation, and we have the disadvantage. And from my point of view, I thought that open question, nobody answers to that question, but we were surprised that almost half of our respondents take time to gauge some advantage and disadvantage. So if we share some advantage report by our provider, it's really the best way of it's less risky for infections during this pandemic. And also a lot of comment about the efficiency of using this new technology, and it's easier for patient and provider to not travel. And a lot of provider report that it was a good way to work from home. And also, as you may aware, using one of missing part of using telehealth, and partly because it was mainly through telephone and not video, it's the lack of physical examination and the loss of human contact in a therapeutic relationship. So we're gonna dig a little bit more, because obviously we have a lot of interesting results regarding the qualitative component. And finally, at the end of the questionnaire, we asked, are you willing, or what is your plan when we're gonna be in past pandemic practice? Do you think you will still use telehealth in your practice? And it's really the vast majority said that I still want to continue use this technology as a complementary way to deliver care. So that's it. It's a high level of our results so far. Okay, stop sharing.
Merci beaucoup, Milé. Alors, c'est très intéressant. C'est les résultats très pertinents. Alors, prochainement, c'est Patrick. Patrick, vous êtes prêt?
Oui, je suis prêt. Un instant. Okay, thank you very much. Do you all see my screen and hear me well?
Yes, perfect. We're getting better
Okay.
at this as we go on.
So I'm Patrick Archambault. I'm a professor at Université Laval. I'm an emergency physician and an intensive care physician. And I'm very happy to present on behalf of my co-investigators, Annette Totten, France Légaré, Jean-Sébastien Paquette, Julie Deschambault, Diane Engelhardt, who's our patient partner, Brigitte Laflamme, Elkébir Gandour, Valérie Charbonneau, and Mathieu Moreau. So the project that I wanted to present to you today was a project about adopting exemplary advanced care planning practices during a pandemic. The funding for this project has come from Réseau One Quebec. We've received 100,000 of in-kind, I would say, hybrid funding model. And the background for this project is all about facilitating and understanding how advanced care planning has changed during the COVID-19 pandemic. We know that patients who are frail, older, and have multiple comorbidities are at highest risk of death from COVID-19. And many patients were hospitalized and are still expected to be hospitalized, potentially require intensive care, and a significant portion of these patients could die. One of the challenges during a pandemic is that patient autonomy to choose life-prolonging measures could be restricted as the result of public health directives and also because of reduced resource availability. So these are challenging times for decision-making, and patients and healthcare professionals still need support to make these difficult advanced care planning decisions for patients, and especially with patients. There exists a best practice called the Serious Illness Conversation Guide that was developed by the Ariadne Labs in Harvard and in Boston, which was adapted to the COVID-19 context, that could help reduce patient and family distress by better engaging patients and families in discussing about what's important to them and making decisions that are more concordant with their wishes. Before the pandemic, myself and my co-investigators were leading an international multi-center cluster randomized control trial funded through PIHCI and led through by the Medalark group in the US. And we were testing the implementation of this serious illness conversation guide in 40 family medicine groups in Quebec, Ontario, and 5 US states. The pandemic obviously had an impact on this ongoing trial. Part of what we want to study is the impact of the pandemic on the use of the serious illness conversation guide in these clinics that were already part of this multi-centered trial, but also understanding that in April of 2020, the Ministry of Health in Quebec created a toolbox containing tools, including the serious illness conversation guide, to which our research group had contributed and co-developed with the Ministry of Health to support healthcare professionals in Quebec to lead serious illness conversations with their patients. So this is a snapshot of what the serious illness conversation guide looks like. It's the pocket guide for the serious illness conversation, which helps clinicians in multiple steps and use patient-centered vocabulary and wording to help them understand and lead them in the discussion about what is important to them, understand what their fears are, how to share a prognosis, how to share the clinician's point of view, and eventually lead the patients and family members to make a decision about advanced care planning. You can find this guide and other material of our research at www.primarycareacp.org. And also in Quebec, here is a link and a slide showing that the Ministry of Quebec has released a toolbox containing the Serious Illness Conversation Guide and other tools as well developed in Quebec on the Ministry's health webpage under the Soins palliatifs et fin de vie tab. And you can find all the rich material that the ministry had developed. So the objectives of our project was to understand how serious illness conversation implementation strategies were developed or being rolled out in Quebec, and trying to understand the impact of the ministry's toolbox on the clinics that would already be pre-trained to use the Serious Illness Conversation Guide, and compare them to the clinics that had not been previously trained in using the Serious Illness Conversation Guide. We want to evaluate the frequency and type of documentation about advanced care planning and or serious illness conversations in family medicine groups pre, per, and post-pandemic, and then compare the implementation challenges for implementing the serious illness conversation in the clinics that had already received the training versus clinics that hadn't been trained pre-pandemic. So we were using a quasi-experimental study design using mixed methods to compare the pre-trained clinics to clinics not having been pre-trained. We're going to be conducting chart audits, comparing samples of charts in participating clinics from 3 periods, pre, per, and post toolbox. And then conducting some qualitative interviews with local key stakeholders in each of the participating family medicine groups based on the theoretical domains framework to explore the barriers and facilitators in implementing advanced care planning during the pandemic. The participants of our study are the 6 family medicine groups who are already participating in the MEDALARC trial, and we're going to have a control group of 12 family medicine groups that had not participated in the MEDALARC trial, and these clinics will be in all 4 Quebec PBRNs. We're looking to recruit physicians, nurses, administrators, and patients having experienced advanced care planning and use of the Serious Illness Conversation Guide before the pandemic, during the pandemic, before the release of the Quebec Ministry Toolbox, and after the release of the Toolbox. So our timeline is the study is going to be ongoing in the fall with the retrospective chart review spanning 3 different periods. And in the winter, we'll be conducting our qualitative interviews. And hopefully we'll be able to come back with some results and share them with the group to help better understand how we can support advanced care planning during the pandemic period and also in non-pandemic contexts. So thank you very much, and very happy to take any of your questions.
Thank you, Patrick. And if I could ask you to copy that email link into the chat for all attendees, then people can just click on it and have it open, like they'll be able to easily access it, the one in your slideshow there, just when you have a moment.
The web link or the email?
You had we had a web link. You can also put your email, but you had the web link there as well. That would be super. And just a reminder to everybody that we will have this session recorded and posted on the PIHCI Sport Network Pan-Canadian site. And Jamie will post that link to that website as well later on in our session. Alors maintenant, Jean-Sébastien, je pense que vous êtes prochaine. Est-ce que vous êtes prêt? Patrick, vous pouvez fermer votre vidéo, s'il vous plaît. OK. Jean-Sébastien? You're a bit faint. C'est un peu difficile à vous entendre.
Oh, est-ce que vous voyez mon écran? Non?
Non, pas encore, mais on bien attendre.
OK. Est-ce que ça fonctionne?
Oui.
OK. So,
mais c'est pas encore une... Oui, c'est ça, exactement.
Oups.
Parfait, ça marche.
Je vais juste vérifier. OK. Parfait. Est-ce que vous m'entendez bien? Oui?
Oui, merci.
Parfait. Donc, je vais le faire en français parce que, désolé, mon anglais n'est pas très bon, donc ça va être compliqué. Je vais juste enlever à l'écran ça ici. Donc, mon nom est Jean-Sébastien Paquette. Je suis médecin de famille donc dans la région de Joliette, mais je suis dans le GMFU de Saint-Charles-Borromée qui est affilié avec l'Université Laval. J'effectue également, je suis chercheur pour VITAM, qui est le centre de recherche en santé durable de l'Université Laval. Et je suis professeur au département de médecine de famille et de médecine d'urgence de l'Université Laval. Donc, je vais vous présenter notre projet. En fait, il faut savoir que c'est un projet qui est au début, donc il n'y a pas de résultat. On est en train de finaliser l'éthique. Donc, je vais parler du timeline plus tard. Donc, je vais simplement vous parler d'un aperçu de notre projet. Donc, je l'ai traduit. Donc, c'est Vigie COVID, optimisation de la prise en charge de la COVID-19 par des recommandations adaptées aux citoyens. Donc, traduit en anglais, ce serait Vigie, c'est Overwatch. Donc, using tailored recommendation for optimization of COVID-19 management. Oups. OK. Donc ici, c'est un peu, on est beaucoup, hein, on est à peu près 40 chercheurs. Je n'ai pas été capable de mettre l'organigramme, mais c'était trop petit. Là, j'ai mis les principaux personnes impliquées, mais il y a beaucoup plus de gens que ça. Donc, entre autres, Caroline Réaume, qui est co-PI avec moi. Il y a Marie-Pierre Gagnon, Adrienne Parent, qui est chercheur dans le réseau du RISUC. Christian Chabot, qui est notre patient partenaire. Également des médecins en lien avec la santé publique, donc Ève Dubé, Caroline Huot, qui travaille également à l'INSPQ. Et dans les chercheurs également, France Légaré, Antoine Groux, qui est en lien avec l'unité de soutien et Pulsar et Alliance Santé Québec. Angelo Tremblay et Vicky Drapeau, qui sont en lien avec qui travaillent au niveau là, des habitudes de vie, des chercheurs universitaires également. Et également, on a des partenariats avec un virologiste, donc Guy Boivin, également Mathieu Ménard, qui est chercheur à Vitam au niveau, qui va s'occuper du volet psychologique. Et je voudrais mentionner David Darmon, qui est un chercheur de l'Université de Côte d'Azur, donc qui travaille surtout au niveau de l'intelligence artificielle. Également, beaucoup d'autres gens, là, dont Annick Giguère, Holly Whitman et Christian Gagné. Dans ce projet, donc la clé, c'est vraiment les collaborations. Donc, il y a une collaboration importante avec la santé publique du CIUS de la capitale nationale. Également, beaucoup de support de l'Alliance Santé Québec et Pulsar qui sont basés à Québec. Et comme j'ai mentionné, l'Université Côte d'Azur, on va également avoir un aspect, un lien avec Omnimed qui est au Québec, qui est un DMA, donc en français, on dit dans le fond, c'est ce que les médecins utilisent là, pour écrire leurs notes, donc c'est le dossier médical électronique. Ici, très important, un lien avec le centre Déclic, donc Valérie Bob, qui est une spécialiste au niveau là, de la vulgarisation aux patients, donc qui va collaborer également pour que nous puissions respecter la littératie là, lorsque nous allons effectuer nos interventions. Le projet a reçu un financement du tri-réseau, là, qui était réseau 1, RISUC, et le réseau de recherche en santé des populations. L'objectif de Vichy COVID, en fait, il y en a plusieurs. Le principal objectif, donc, c'est une intervention, c'est-à-dire qu'on veut améliorer les comportements préventifs des citoyens, donc, c'est-à-dire de porter un masque, se laver les mains, éviter les contacts ou les sorties inutiles, selon leurs conditions médicales, mais également selon leur localisation géographique et leur statut COVID, c'est-à-dire est-ce qu'il y a des chances qu'ils aient le COVID ou non. Donc, tout dépendamment de leur situation, les recommandations vont être différentes. Et également, un des objectifs indirect, c'est d'augmenter la détection de COVID-19 dans la population, surtout sachant que chez les gens qui ne consultent pas leur médecin nécessairement, il y a beaucoup de gens qui sont peu symptomatiques, donc les gens ne sont pas nécessairement au courant qu'ils ont la COVID-19. Donc, un des buts, c'est d'augmenter cette détection-là pour aider au niveau de la santé publique et donc d'anticiper la deuxième vague. Un troisième objectif, c'est avec le questionnaire. Vous allez voir, les gens vont remplir des questionnaires. On veut utiliser l'intelligence artificielle pour découvrir des nouveaux symptômes qui peuvent être liés à la COVID-19. Et ceci est déjà fait en France avec l'Université Côte d'Azur. Et dernier objectif, donc c'est une première fois, en fait, que c'est une proof of concept de collaboration avec la santé publique, la communauté, puis les médecins de famille. Donc, je vais y aller très rapidement. Là. Donc, le comportement préventif des citoyens, c'est la clé là, pour essayer de réduire la propagation du COVID-19. Ce qu'on appelle en anglais les tailored recommendations, on traduit par recommandations adaptées. Ce n'est pas la même chose que recommandations personnalisées. Là, on a fait la distinction. Donc, c'est plus efficace que les recommandations générales pour essayer d'influencer les comportements des citoyens. influencer positivement. Comme je l'ai mentionné tout à l'heure, il y a beaucoup de citoyens qui ne sont pas au courant qu'ils ont la COVID-19, puis ils ne vont pas consulter de médecins. Donc, ça amène un sous-diagnostic dans la population, puis une augmentation du risque que ces gens-là continuent leur comportement sans être conscients du risque que ça le peut apporter. Donc, on croit qu'en utilisant une plateforme citoyenne, que ceci va augmenter la réalité, c'est-à-dire va donner un meilleur portrait de la pandémie dans la communauté. Donc, la méthode, donc à l'Université Laval, nous avons le Pulsar qui va s'occuper de mettre en place la plateforme et qui est un endroit sécurisé pour les données. Grâce à cette plateforme-là, on va pouvoir avoir des questionnaires sur l'histoire, les antécédents médicaux, la condition médicale actuelle du patient, est-ce qu'il est en train de décompenser son diabète ou sa MPOC, donc comment va le patient au niveau médical et donc physique et psychologique, et aussi est-ce qu'il y a des symptômes reliés à la COVID. On va également recueillir des informations au niveau géographique, la localisation géographique, puis sur les habitudes de vie, c'est-à-dire le sommeil, l'exercice et la nutrition. Nous avons développé un algorithme avec la santé publique qui va être utilisé pour aller associer donc, le risque du patient ou sa situation actuelle avec une recommandation. Donc, il va y avoir des questionnaires plus petits qui vont être donc moins longs, qui vont être retournés au patient à différents moments, tout dépendamment de sa situation. Donc, si le patient va moins bien, à ce moment-là, il va y avoir plus de questionnaires plus rapprochés, mais quand ça va bien, donc là, ça pourrait être plus échelonné. Donc, et on va également évaluer le comportement du patient, donc selon s'il porte son masque, est-ce qu'il respecte la distance. Donc, il y a différentes variables là, qui sont déjà décrites dans la littérature qu'on va mettre dans les évaluations. Les recommandations qui vont être données aux patients vont être faites par courriel. On va vérifier avec la santé publique, on a une collaboration à toutes les semaines, on va vérifier si les patients ont été testés pour le COVID et quel est le résultat de ces tests. Et également, pour ce qui est des recommandations et des zones géographiques, il va y avoir ce qu'on appelle des mises à jour continuelles avec la collaboration de la santé publique. Donc, le projet, il y a eu des légers retards. C'est sûr que c'était l'été. On a eu le founding un peu plus tard. Donc, le projet pilote devrait être sorti pour la mi-septembre. Et puis, pour la plateforme officielle dans la région de Québec, ça va être à la fin septembre. Ensuite, il va y avoir des ajustements et on espère pouvoir faire une mise à l'échelle provinciale au mois de novembre. Et éventuellement, cette plateforme, donc quand la pandémie va terminer, on aimerait l'utiliser pour suivre les maladies chroniques et les autres épidémies qui ne sont peut-être pas des pandémies, mais qui pourraient avoir une utilité avec la santé publique. Également, j'ai oublié de mentionner dans l'introduction, dans la méthode, quand on voit qu'un patient est en détresse, on va lui demander, donc on va lui faire des recommandations, mais parmi celles-ci, on va demander l'autorisation au patient s'il accepte que nous envoyons une information à son médecin de famille pour que lui puisse lui communiquer. Donc, on va établir un réseau de communication entre le médecin de famille, la santé publique et le patient. Donc, je vous remercie pour votre attention. Le site n'est pas encore actif. C'est moi qui est en train de le produire. Donc, ça va marquer que c'est in progress. J'ai mis le site de mon laboratoire ici à Joliette. Et donc, merci à tous les partenaires. Il y en manque. Là, il y a beaucoup plus de partenaires que ça. Mais ce sont les principaux partenaires. Il manque Pulsar. Je n'ai pas été capable de mettre le logo là, sur la diapositive. Merci beaucoup.
Merci, Jean-Sébastien. Again, if that's something you want to copy and paste into the chat, alors ça va être plus facile pour tous les participants de faire access. Et puis, arrêtez de partager l'écran. Nadia, je pense que vous êtes prêts. Est-ce que vous êtes prêts pour commencer?
Yes.
Votre... OK.
Is this okay for everyone?
Perfect. Go ahead.
Perfect. Thank you, Jill. It's a pleasure for me to be here today and present this project to you all. So my name is Nadia Soriol. I'm an assistant research professor at the Department of Family and Emergency Medicine at the Université de Montréal, and also a regular scientist at the Université de Montréal Research Center. And started as an early career investigator just days before confinement measures came into play in Quebec. So this is an interesting career start for me, a very exciting also to be part of efforts to help in this crisis. So this study focuses on trying to bring forth timely and practical evidence on the impact of social vulnerability in older persons in Quebec during the COVID-19 crisis. And specifically, the type of social vulnerability this project is looking into is social isolation. We know that social isolation has really come to the forefront as a public health concern because of the pandemic. And it's really become clear that this is an ongoing public health issue that will keep going with ongoing waves and periods of confinement. And even under normal circumstances, social isolation is now known as the new smoking, with risks of cardiovascular disease, mental health, mortality rivaling that of smoking, obesity, and hypertension. And so with these unprecedented COVID-19 measures and disruptions to access to care and social services, this is really a key vulnerable population that needs to be focused on. In particular, in Quebec, not only is it the province facing the brunt of the pandemic in Canada, but also the province with the highest rate of socially isolated persons in the province. There is even in the news today a new report showing that 30% of older persons are feeling socially isolated. So this project brings together a broad range of expertise from senior and junior researchers, as well as trainees, and as well as community partners, including Les Petits Frères, which is a nonprofit organization that partners older persons with volunteers who are with older persons who are in situations of isolation with volunteers, as well as the SE Research Center in Ontario and Quebec Integrated in Health Social Services. And this is really a participatory project so that partners can provide input as the study goes along and benefits from the expertise, as I said, from researchers coming from four universities across Quebec and Ontario. It's also funded through the Réseau 1, as well as 3 other funding sources, and through sources funding through one of the co-investigators. So this project is a 1-year project that has 3 objectives. I will be focusing on the first objective for this webinar. So what we're trying to do here is to first better describe the profiles of socially vulnerable older persons in Quebec. And again, particularly focusing on the subset who are socially isolated, and then to examine the association between social vulnerability and mental health and health service use outcomes to better understand the increased risk in this population to have poor outcomes during this period. And then to be able to speak with older persons who are in this situation and identify met and unmet needs during this period to be able to, in the end, provide practical recommendations and input back to partners and the primary care community to better support this population through the ongoing pandemic. So today, as I said, I'll be focusing on the first objective to describe the profiles that we found with our first set of data. So the data comes from an online telehealth tool that was put together by Olivier Beauchet, who's at the Center of Excellence in Longevity at the Jewish General Hospital. And this tool was meant to provide a screening method for at-risk isolated older persons. And so using this data, we were able to then look at what were the characteristics of the socially isolated subset of this population based on their health characteristics, physical, mental, and cognitive characteristics. So we looked at socially vulnerable people who were living alone with no access to external contacts, and used a supervised machine learning method called latent class analysis that is used to be able to look at a population and find similar subgroups within the population that have different profiles. So considering that this population may not be all similar and may have different characteristics, and to be able to characterize those. And so we had data on 380 older persons who were considered socially isolated, meaning that they were living alone with no external contacts. And through latent class analysis, we found 3 distinct classes within this population. So the first class, I'm going to talk about class number 2. This really stuck out as a subgroup that were older and had more signs of physical frailty, including increased use of medications, requiring help at home, walking aids. So this seemed to really come out as a group that were older and more physically frail. In contrast, we found a second class where we found them to be younger, but having more signs of anxiety and requiring more help from nurse and social care. So we have 2 contrasts of older and physically frail compared to younger and more anxious, and a third class, which actually seemed to be doing quite well. And so this was very interesting in terms of trying to understand whether traditional definitions of social isolation may be capturing people who, while meeting the definition of social isolation, may either be doing quite well, even though they're living alone with few contacts, or maybe there's other subtle reasons for social isolation that we're not picking up. And so the conclusion of this early preliminary work is that it's important, we're really seeing the importance of identifying and supporting the socially isolated population in the community, and that given the heterogeneity in this population, we really recommend that interventions and screening tools need to be mindful of the different profiles and perhaps adapt questions and methods to consider different pathways into social isolation in this population. So thank you very much for your attention. I look forward to your comments.
Thank you, Nadia. We have now our last presenters, and then hopefully we might be able to have a word from our patient partner afterwards, although I'm not certain he was able to join. So now it's Rick and Kevin. If you want to go ahead and unmute yourself, and I believe Kevin is sharing her screen. Karen, we don't quite have the correct view yet. And Rick, are you off mute?
Yeah, I'm off mute. Can you hear me well?
Yes, and Karen, that's perfect. Okay, go ahead.
Okay, so Karen is going to manage the slides. So my name is Rick Fleet. I'm an emergency physician and clinical psychologist. I'm a professor at Laval University, and I study rural emergency care. And we want to thank Réseau 1 for this funding, congratulate all participants today. And thank you, Jillian. So we're going to be talking about implementing innovative solutions to improve rural healthcare in the context of the pandemic, in the context of design thinking in our Charlevoix Living Lab hospital or hospital experience. So I'd first like to thank all of my co-researchers. A few of them are here, including Mylène, and thank all of our participants, citizens, and decision makers from the area of Charlevoix. So next slide, please. So we've been studying rural emergency care for the last 10 years. And in particular, in the last years, we've actually conducted a qualitative study called Urgence Rurale 360. It's a study where we've interviewed over 200 stakeholders in rural emergency departments, all of the 26 of them in Quebec, where we sought to find what are the challenges and what are the solutions to improve rural emergency care. And there are big discrepancies between rural and urban emergency care in Canada. We've showed that there are really significant consequences on your mortality if you live rural or urban in terms of emergency care. So after this, we said, what's the next step? So the next step for us was really to see how we could deploy these solutions. And one idea we had, and it was launched in the area of Charlevoix, was really to create a living lab hospital. And it was in this new hospital in Baie-Saint-Paul, where we said, we're going to prioritize the solutions to improve care based on citizens and healthcare professional local needs and demands. So we used design thinking to do this, but then the pandemic hit. And so we said, what do? Do we stop? What solutions do we kind of need to deploy? And so we surveyed all of the rural emergency departments in Quebec again. And people said, you know what, we're scared. We're scared we're gonna lose doctors because there are not too many people on the bench, not too much backup. We're scared we won't be able to critically manage these patients, transfer them adequately. And then we kind of threw out the idea of maybe we should deploy teams of residents. Initially, it was senior residents in these areas, like multidisciplinary teams. And then we kind of thought that that would be complicated. So we got the idea of maybe we should deploy just a few residents in the living lab hospital, so in one hospital, and then eventually upscale this. So we started off basically by creating a residency rotation to help improve the care. So this is all based on design thinking, which is basically based on observing, imagining, so there's a creative process, and actually doing prototyping solutions. You can go back to the next slide, Karen. So this study is actually a description of this. So we created this rotation where we actually focus on what's the state-of-the-art management of a pandemic in a rural setting, what's the evidence there? So we have leadership. We teach them leadership skills inspired by the International Masters of Health Leadership program, of which I'm currently a student. Then we brought in wellness strategies and of course, rural medicine. So the residents are on 1 to 3 month rotations. They're also immersed in 2 rural hospitals where they actually see what they can do. So this study is basically focusing on them leading innovation teams. So they actually lead a team of local doctors, decision makers, and healthcare professionals, and they choose an innovation to implement. And in the context of this pandemic, we will present you one of the innovations that was implemented by our resident. And so Karen, you could take it from here.
Alors, merci Richard. Bonjour tout le monde. On a actuellement peut-être entre 5 et 7 projets qui avancent et puis les résidents sont invités à travailler sur l'un d'eux. On va vous en présenter, on a choisi d'en présenter un qui est presque que terminé, là. Alors, c'est une résidente, Isabelle, qui a discuté avec des médecins locaux. Puis, on est en contexte où la région de Charlevoix était fermée. L'ouverture de la route était annoncée et là, on s'attendait à une arrivée massive là, de touristes pour l'été, évidemment. Et puis, les médecins étaient inquiets à se demander comment on peut accueillir les touristes, mais en étant protégés le plus possible et tout ça. Et donc, Isabelle, notre résidente, s'est dit, OK, je vais m'intéresser au port du masque. Alors, à ce moment-là, le port du masque n'était pas obligatoire. Elle est allée consulter la population, donc vraiment la première étape du design thinking, pour comprendre qu'est-ce qui faisait que les gens le portaient peu, ce qui était le cas dans Charlevoix. Et elle s'est aperçue qu'essentiellement, les gens, quand ils le portaient, se sentaient marginalisés parce qu'il y avait très peu de personnes qui le portaient à ce moment-là. Et donc, elle a souhaité faire un projet pour augmenter la popularité du masque, qui est devenu un projet d'adhésion au port du masque suite à la mesure là, obligatoire. Et finalement, avec l'équipe dont Richard a parlé, ils se sont assis ensemble et ont développé un projet en 3 volets. Donc, le premier volet était une activité, en fait, où les gens étaient... on a invité des artistes peintres de la région, donc de la relève, mais aussi qui sont reconnus de façon internationale, à venir peindre sur des masques, les masques fabriqués par les grands ballets canadiens. Et l'idée était vraiment de créer des masques que les gens sont fiers de porter avec les artistes de la région et tout ça. Et il y a eu des allocutions, entre autres avec Dr. Joanne View, puis une grande couverture médiatique là, pour les médias locaux, donc la télé, la radio, etc. Et puis, évidemment, tout ça s'est fait dans le respect des mesures sanitaires. Puis, on pense avoir touché aux alentours là, de 150 personnes environ. Ensuite de ça, il y a eu les 2 autres volets du projet, donc un montage photo, mais aussi un montage vidéo avec des influenceurs de la région qui se positionnent en faveur du port du masque. Et puis, on va vous présenter une vidéo qui dure 30 secondes, mais qui, finalement, va vous montrer le résultat. Alors voilà, donc c'est un exemple là, des projets là, qui ont eu lieu avec les résidents.
Merci tout le monde. Merci Karine.
Okay, merci beaucoup. And now just before we go to the question and answer session, we have one of the patient partners for Réseau 1, and that is Christian Chabot. Christian, is there anything you'd like to share with the webinar attendees, même en français, before we go to the question and answers?
Oui, bonjour.
Oui, bonjour, vas-y.
Je vais y aller, ça ne sera pas long. Je vais me placer. Okay. Bonjour tout le monde. Mon nom donc est Christian Chabot. Je suis un patient partenaire depuis plusieurs années au Québec. En fait, il y avait une question comme telle qui concernait, si vous voulez, qu'est-ce qu'on devrait faire en tant que patient partenaire comme tel pour la seconde vague. Et écoutez, je vais prendre un peu de recul sur la première vague. La première vague, moi, en tant que patient, évidemment, j'ai un peu souffert de la promotion ou en fait, de toute la publicité qui était faite sur le COVID-19 comme tel. Comme je n'ai pas eu le COVID-19 et je suis un patient avec plusieurs pathologies, j'ai évidemment eu peur de rencontrer mon médecin de famille. Je n'ai pas sollicité les urgences, même si j'aurais pu ou parfois j'aurais dû. J'aurais été probablement beaucoup plus tolérant envers moi-même que d'aller des urgences, de peur de combattre, si vous voulez, ou d'attraper le virus. Malheureusement, le gouvernement a fait un bon travail de gestion, mais je ne me sentais pas interpellé par, si vous voulez, par le COVID-19 en tant que patient avec certaines pathologies parce qu'on ne parlait pas de mon cas à moi. Qu'est-ce que je fais si je me sens mal? Les conférences de presse l'après-midi, c'est juste pour le COVID-19. Donc, je ne suis pas senti interpellé beaucoup par toute la publicité qui était faite sur le COVID-19. Remarquez bien, le gros problème qu'on va avoir, c'est après le COVID-19, après la vague numéro 1, comment on va faire pour retourner les patients rencontrer leur médecin. On voit qu'actuellement, dans les urgences, le taux de patients est quand même pas très élevé. C'est ce qu'on apprenait hier, justement, dans les nouvelles. Moi, en tant que patient partenaire, ce que j'aimerais évidemment, c'est m'impliquer dans les projets de recherche qui peuvent aider à atteindre l'ensemble de la population, autant ceux pour le COVID-19 que ceux qui ont besoin d'accéder à des soins de santé. Je voudrais également en profiter pour faire la promotion. Malheureusement, quand on est dans la recherche, on ne fait pas beaucoup la promotion de ce qu'on fait. On ne l'amène pas au public et il faudrait trouver une façon d'atteindre le public. Et dans un des projets auxquels je participe actuellement, qui est un projet de M. le docteur Jean-Sébastien Paquette, qui est Vigie COVID-19, c'est d'essayer en fait, d'amener ce projet-là avec notre réseau gouvernemental, c'est-à-dire Québec.ca, qui est, si vous voulez, la porte d'entrée citoyenne à les saines habitudes de vie ou les solutions au COVID-19, mais ce sont des solutions administratives. Donc, si on pouvait changer les comportements des gens, amener une adhésion à travers ce portail-là qui que le message soit fabriqué par des patients partenaires destinés à la population. Je pense que ça aurait un impact super intéressant. De toute façon, il faudrait le mesurer. Et si dans le projet Vigie COVID-19, je peux me permettre de réaliser ça, ben, j'aurais atteint un objectif qui pour moi serait intéressant parce qu'établir un lien avec le gouvernement, étant donné que le gouvernement gère la santé, je pense que ce serait super intéressant. Voilà.
Merci beaucoup, Christian. Alors, à ce moment-là, on va aller à les questions. Si jamais les personnes ont les questions, mis dans le Q&A parce que c'est plus difficile d'aller dans tous les commentaires pour le chat. So, I think I'm going to start. There was one question that was for Milan. I'm going to read it out because questions in the Q&A are not, the audience members can't see them. So the person was wondering how family physicians are paid in the FMGs or GMFs, and how, if at all, does RAMQ compensate providers for different forms of telehealth that you listed? So Milan, yours, you talked about email, video cards, phone calls. I know this is a huge issue, North America, Canada, Quebec. So if you can share some insights, vas-y.
For sure, it was the first barrier of adopting telehealth was the way that physicians are paid. And since March 15, they have a new fee code from RAMQ to use to bill for telehealth, firstly for telephone and video. So it's less an issue right now. I don't know if it's going to stay after the pandemic, but I guess they're going to have pressure to keep that as a new fee code.
Okay, thank you. And I think one of the issues that a lot of clinics are struggling with in terms of payment and revenue and everything else is that often these fee codes are not commensurate with the care being provided. So est-ce que ça c'est le cas ici? RAMQ, for those of you across Canada, is our public health insurance. It's the Régie d'assurance médicale de Québec. And they pay our clinicians on a fee for service. Depending on the thing, we won't get into that, but a lot of them are fee for service. Est-ce que c'est moins, Milan? Est-ce que c'est un problème? Vous pensez?
That's a good question. I don't have the answer, but definitely in 10 minutes, before 10 minutes, I'm going to give you some number of the way that have been used, how many physicians have used this fee code in Quebec, and it was tremendous. We can think both specialty and physician. And in the research I present to you, it was for sure it's a challenge for physicians, but it also we show that other primary care providers use this technology and they are less sensible of this issue because they are paid based on salary. But maybe something that show that it's not specifically to the way that the physicians are paid, but also to have access to the material to use telehealth. So mainly it was by phone, by their home. They use their home technology. So if we want to go forward, we have to invest in materials such as having a laptop that you can have sharing video. So I think for a modern system, we must invest more to have this material available for every provider.
Yeah, that's certainly right. C'est beau. I think that's certainly been an issue. It's come up in our other learning series that we are kind of hoping because people didn't have to drive and take time off work to see a clinician by doing virtual care, it would improve our access and equity issues. But not having this setup with a nice camera, a funny background, a good mic, and yeah, that people are using their home systems. And I think we've all discovered the hard way that when there's more than one of you using the home system for more than one thing, suddenly it's like, and you're like, oh, great. So I think maybe I think what we need to think about is how we advocate for ensuring that Wi-Fi is a utility, not a luxury. So we've got to make sure that happens. And merci beaucoup, Milan. So I have another question. This was for Eric, and the person was asking if you have patient or public partners on your research team helping determine the dimensions you will measure when determining cost.
Yes, I would like to answer in French, Peter. I think it's better.
Oui, vas-y, je peux faire la traduction.
En fait, ce qu'on va faire, c'est on va utiliser une approche Delphi qui va consister à valider au niveau du développement du questionnaire. Et parmi les experts que nous avons, effectivement, on aura les décideurs. Dans les gens, les décideurs, on aura les infirmiers en prévention et contrôle des infections, on aura les médecins, on aura d'autres intervenants, les préposés aux bénéficiaires, les infirmiers auxiliaires. Et on avait prévu effectivement dans le projet inclure ne serait-ce qu'un proche aidant, ou bien donc quelqu'un, un ou deux proches aidants qui peuvent aussi répondre à nous aider à valider le questionnaire pour être en mesure de pouvoir avoir l'ensemble des coûts, notamment tout ce qui concerne la qualité de vie. I think it's okay.
So if I understood well, you have many stakeholders involved, like decision makers, nurses, and different healthcare providers. Did you say that you've got patient partners validating your quality of life?
We don't have a specifically, we don't find now to get a patient partner because we work with residents in long-term care facilities. We decided to use those loved ones.
Okay, family members.
Yes, family members to help us to validate this question, the questionnaire during the Delphi approach. So we decided to first, after building the questionnaire, we're going to use around 20 experts in the specific background, including also one or two experts with live ones can give also the information about the quality of life of the resident or the person of their families included inside the healthcare, long-term healthcare facilities during the pandemics. Is it okay?
Yes, oui, c'est parfait. So it's more, it would be what we would call community partners because you're using the family members to help you.
Yeah, it's not patient partner, as you said, but it's family members who can give us all information about their resident, the time they spend, because we have now, we have the loss of time during the pandemics. All the visits of the visit of residents are postponed or as canceled. So we have also the impact in the quality of life of the resident inside the long-term care facility. So we are going to estimate a little bit the loss of time these residents, the time they are going to lose, they're supposed to lose maybe 2 years or 2 hours per week, because sometimes before the pandemic, their family came and just visiting the resident maybe 2 hours per week or 2 hours per couple of weeks. So we are going to collect this kind of information and also explain how, and also try to measure the problem related to the loss of the good quality of life. You have also the time of watching TV, loisir, the time there are some activities residents make inside, and these activities where we decided to where it's postponed or to cancel during the period of the pandemic. So we are going to explain and measure also the cost of this loss of time on daily.
Okay, merci beaucoup. C'est très intéressant. And I think really happy to see one of the projects in the long-term care homes. I don't think Quebec is unique with the concentration of COVID-19 in those homes and discovering issues that maybe others knew about, but now are really being magnified with the pandemic. So merci, Eric. C'est très intéressant. Okay, we have another question here. It's a question for Nancy. And this is similar. And Nancy, the attendee, is wondering if you can describe how patients and families were involved in your project as part of the research teams. There's a lot of interest in the patient partnership.
Merci pour la question. Je vais répondre en français. Donc, dans le cadre de notre projet, je dirais que on a un patient partenaire qui vient d'être identifié, donc qui va être très actif là, pour la phase 3 et la phase 4 du projet. Donc, la phase 3, c'est vraiment l'identification des pratiques qui vont être implantées dans le GMFU témoin. Et la phase 4, c'est vraiment la phase d'implantation et d'évaluation. Donc, malheureusement, on n'a pas pu impliquer là, un patient partenaire pour toute la phase là, de l'écriture du devis et la première phase parce qu'on était un peu contrainte là, par des contraintes de temps. On a dû écrire rapidement et au CIUS de la capitale nationale, on doit passer par un bureau, le bureau des patients partenaires pour avoir accès donc, aux usagers partenaires. Donc, ça peut être parfois un délai plus ou moins long. Donc, malheureusement, on va intégrer là, un patient partenaire pour la troisième et la quatrième phase là, du projet. Donc, je ne sais pas si ça répond à la question.
If I understood that well, so you went through, there's a specific office you need to go through to get your patient partner. And because of how fast these projects went, they weren't involved in the first two phases of the project that included the literature review, but you did have a patient partner identified who is very active in phase 3 and 4, which includes implementation and evaluation of the project.
Yeah,
correct?
That's it. Yeah, that's correct.
Okay.
That's very good.
So, I'm trying to type that in English at the same time. So, all right. So, yeah, this has been the challenge. So many of these projects were meant to be done very quickly to give us real-time information, and patient partnerships are built on relationship. And you know, if you're trying to do something new and you need somebody new, the timeline doesn't necessarily match. But I do know, and maybe Christian can comment a little bit more about this. I know that the patients are very, very interested in these projects and having a say in them. So, and obviously from the questions, a lot of other people are interested. Does anyone else want to comment about patient partnerships in their projects, or lack of patient partnerships, why that might have been that way, or what you might be going ahead in the future? We've already heard from Eric. Christian, did you want to comment?
Oui, ben en fait, je trouve que malheureusement, le rôle du patient partenaire n'est pas très connu dans la population comme telle. Je ne sais pas comment aller chercher des gens qui pourraient être intéressés à s'investir, dans le fond, à titre de patient partenaire. Dans le fond, ça facilite l'engagement, ça facilite le développement des connaissances. Moi, j'ai appris énormément à travers les différents projets que j'ai faits. Mon expérience a servi également à travers les différents projets que j'ai pu participer. Puis j'ai toujours considéré que plus les gens sont investis dans leur propre santé, ce que le patient partenaire amène, la notion du patient partenaire amène, c'est que on est des meilleurs partenaires du réseau de santé. Et avec le manque de ressources dans le réseau de la santé, on entend souvent parler évidemment du manque de ressources, mais je pense qu'une partie de la problématique en termes de ressources pourrait être très bien prise par la population dans l'engagement de sa santé. Si on s'intéressait à la santé, si la santé devenait quelque chose de facile à comprendre, souvent on utilise des termes trop scientifiques, les gens ne comprennent pas toujours, donc le niveau de littératie est super important dans ça, mais s'il y avait une campagne de la promotion de l'implication du patient à devenir un patient partenaire, un proche aidant, ce serait super intéressant, mais on entend parler par les politiciens quand on en a besoin, mais malheureusement, c'est pas sur la table là, comme tel politique. C'est un côté que je trouve un peu désolant comme tel, parce que qu'est-ce qu'un patient partenaire amène comme valeur au réseau de la santé? Je pense que ce serait très bien de définir c'est quoi la notion de la valeur que ça amène à un patient partenaire. Puis je pense que ça contribue énormément à faire avancer les choses. Et on prend souvent des exemples, on a vu des différentes annonces sur la COVID-19. On a vu des annonces qui touchaient aucunement la population. Peut-être que quand on a commencé à mettre des vrais contextes de vie, ben là, probablement que les gens étaient plus intéressés à écouter, ça les touchait plus que des éléments, des artistes à lesquels tu ne vous identifies pas comme tel. Voilà. Je pense que donc la notion de patient partenaire devrait être beaucoup plus promouvoir la notion du patient partenaire. C'est une question de... En tout cas.
Okay, merci beaucoup. I know for our network of networks, including the réseau, the patient partnership is so critical, and it's such invaluable information. We do work, each of the networks has their own network of patient partners, as well as a Pan-Canadian Patient Advisory Council, and I work with the Quebec members on that, and it's just incredibly helpful. There's just so many things that we wouldn't think of because we don't have the lived experience. We're book smart as researchers, but not necessarily. As one of my father's quotes that I always enjoy is that education is a poor excuse for intelligence. So we need the intelligence that patients bring to the table for us. Okay, is there anybody else that wants to comment before I go on? We've got a couple of more questions. Everybody's not fast off the mark on their mute button. I'm going to, yeah, we got 3 more questions. So there's Nadia, there's a question for you. The person mentioned, you mentioned comparing or finding class with the population. Do you mean the population which you have data off of, or the whole population?
Yeah, so ideally, what we would like to do is to be able to profile the entire population and find out exactly what are the characteristics of all socially isolated older persons. And so when we don't have access to the entire population, as is the case in this case, we're using already available data through an online tool to get a proxy idea of what's going on in the population. And the results that we'll be getting or that we'll be sharing with our community partners will really be important to get their feedback to see if this matches with what they see on the ground. So that's going to be one way of validating if the profiles that we're seeing stick with the types of people that come to them with these needs or that they're identifying in the community. So that's one way of knowing if the results we're seeing are somewhat generalizable to the population. Although it's always a good plan and with other data sources to look at, if this replicates in other populations and other provinces and see if we're missing other potential profiles of social isolation that we need to consider.
Okay, thank you very much, Nadia. Yeah, it's super interesting, and I know like you said, social isolation is definitely the new smoking, which a lot of people have managed to give up during COVID, but so now we've got a new risk factor. Okay, so the next question for Patrick. Thank you. Thank you for your presentation. What is your rationale for choosing the theoretical domains framework for your qualitative work? And is there a follow-up study after your work? So they're asking you to identify behavior change techniques to modify identified behaviors and facilitators. So an easy question, Patrick. It's always fun to justify our theoretical frameworks, which only those who we tend to use them more in qualitative research. So I have an idea why you used it, but why don't you share with our audience members about why you would have taken that approach and some of the plans for afterwards?
Well, I would say that it wasn't really a very deliberate decision to use the theoretical domains framework. I would say it's more of an experience in its previous use in other projects. So I felt comfortable in using it, but from my previous use and my understanding of how the theoretical domains framework was created by Susan Mickey was its very systematic approach to including different constructs from different domains within behavior change. And so I really appreciate how systematic they were in looking at multiple theories of behavior change in developing the theoretical domains framework. So it's very encompassing and inclusive in its exploration of different barriers, facilitators, and factors in behavior change. I would say it might be a bit light on the organizational aspects of understanding how change occurs in complex systems, but it still does have part of organizational change built within the theoretical domains framework. I also like the fact that the theoretical domains framework is integrated within the behavior change wheel and is associated and linked. So the different domains that you can identify are linked to specific, I would say, evidence-based behavior change techniques. So yes, we would eventually like to use the domains that we identify as barriers and facilitators to act on using, I would say, proven, but somewhat sometimes not proven behavior change techniques to help us guide us in what interventions we might be able to implement in future studies, looking at how to improve advanced care planning. And it's a complex problem that we need to address, and probably doesn't have one single behavior change technique that needs to be implemented, but the theoretical domains framework can help us identify which are the most important domains to address in change management. So that would be my very simple answer to a complex question.
Yeah, and you have my sympathy. I think last time I tried to use theoretical, well, not last time I tried, I've used theoretical frameworks all the time in implementation science, and I usually need to combine about 3 or 4 to get a full capture of what's going on. People tend to focus on one specific area in our health system, and people's behaviors within it are so complex that it's really hard to capture it all, but at least it helps organize your thinking. Yeah, it's.
I can add to that, Jillian, the fact that we are hoping to add a recent work done by Ali Ben Sharif, who is France Desgarais' postdoc student, and has published a framework to use on assessing sustainability, not sustainability, scalability of interventions. And we're going to add that as well to our framework on assessing the scalability of the intervention that we're trying to implement. So you're right that it's not one single framework that we're going to use, but we're going to explore Ali's evaluation tool about scalability.
Perfect. That's wonderful. I'd love to see more on that. So we have a final question, and then I'm going to go into the wrap up and conclusion. So this question is a general question for all our speakers, and the question is: primary care had to adjust quickly to provide patient care during COVID-19. Is primary care going to be better prepared to provide care when we go through wave 2? So I would expand that to say, is primary care and is primary care research going to be better prepared as we go through wave 2? And I'd also like our speakers to comment on something we describe as wave 3 and 4. Nadia touched briefly on wave 4, which is mental health, that there's going to be a big uptick in mental health conditions exacerbated by COVID-19. And wave 3 is the chronic conditions. And I think, Simon, you have something to say about that. The chronic conditions and cancer and other things and surgeries that have been pushed aside and are now seriously impacting people's health. So Simon, why don't you go ahead and start? And then I think Jean-Sébastien, you also had something you wanted to say. So Simon, go ahead.
Yeah, so thank you very much. So there is, I listen to a lot of podcasts from the United States from experts in infectiology, and I get very interested in that topic. And what I understand now is that the concept of second wave, the experts don't really think it's like the definition of a second wave is that it disappears and then there is a resurgence. And what we see with this pandemic, it's just continuous. And so the definition here of the second wave is that you open more, you open school, you open more workplace. And so it's not just a second wave, it's just trying to get back to normalcy. So when you think in that mindset, you don't think only about wave, but about reconstructing and about the long term. And as you said, there will be issue with reconstructing primary care for mental health and for chronic disease. And I also add there is this new topic that's coming about the long COVID patients. There was an article by Trisha Greenhalgh last week in the BMG, and it's expected that we will have 10% of all cases that will develop long-term sequelae from COVID-19 that can prevent them from going back to school or going back to work. So just put the numbers in perspective, it's more than 5,000 cases only in Quebec that may fit in this long COVID patient categories. And so this is coming to primary care. It's not a hospital-based issue. It's really about primary care. So there is a lot of work in the next few years to help support primary care teams. And so this is what's coming. And this is why all the projects that are presented today that cover a lot of different fields within primary care are so important. Just so that's it.
I absolutely agree with you, which is why I expanded the question to include researchers, because my hope, we know primary care is a foundation for high quality, high performing healthcare systems. We also know we're struggling a lot with doing it well or having a consistent primary care approach. And really, COVID and the pandemic has been a serious pressure point for everything, research, healthcare, everything. And I'm really hoping we can be keeping up in the research and providing answers that when we reconstruct, we don't put it back the same way, that we rebuild to be better and stronger and more resilient and more to these sorts of stressors. And I think it's been a huge wake-up call. We all knew in research in the primary care world, we knew this was an issue, but now it's apparent to everybody that our system is not prepared for this, and hopefully we can do better. And I'm very encouraged by the results of a lot of these projects in providing insights into ways that maybe we can do this a bit better and be more responsive to the population needs. Patrick Jean-Sébastien, did you want to add to that? And then Patrick?
Oui, je vais y aller en français. En fait, simplement pour moi, c'est plus l'aspect clinique. Au niveau clinique de primary care, il y a quand même eu beaucoup d'améliorations parce qu'au début, les gens avaient peur, c'était un virus inconnu, donc tout a été shut down. Et il y avait aussi des grosses lacunes au niveau des résidences pour les personnes âgées. Il y avait « There is no doctors at a nursing home ». Je ne sais pas comment on dit, les résidences qui ne sont pas des CHSLD, mais c'est surtout des foyers pour les personnes âgées autonomes. Donc, il n'y avait pas de structure, alors que le système s'est organisé rapidement pour soigner ces gens-là, puis avoir des médecins de garde, même qui vont à domicile. Donc, je pense que pour la deuxième vague, ou comme a dit Simon, pour le continuous infection, je pense qu'on est mieux préparé au niveau clinique. Mais effectivement, on va découvrir des nouvelles facettes du virus qui vont être lourdes et qu'il va falloir s'adapter encore. Donc, c'était simplement pour dire que au début, effectivement, c'était comme si tout avait arrêté et il y a eu beaucoup de problématiques qui en sont suivies.
Yeah, absolutely. It's the chronic conditions that aren't receiving the follow-up they need. I think it was a study in Scotland that documented already increases in mortality from exactly that. And that's in terms of the research world, that's horrifying how fast that has appeared and been able to be measured. So that's really quite distressing for all of us who work in this world. Patrick?
Yeah, my reflection is more along the lines of learning how we can better support the creation of a learning health system where we have better access to data so that we can see these second, third, and fourth waves come at us much more reactively, and we can find solutions much quicker. I think researchers in the last few months have had lots of great ideas. We've been funded for research, but we're still struggling at getting access to the to the data. I think patient partners have an important role in supporting us as researchers, but also us as researchers supporting patients to help us open up the sort of the very, I understand the issues about privacy and that's really very important, but our information is still captured in silos, and the information is just not available for us as researchers to make adequate diagnoses and create new ideas for solutions. And I'd really like the researchers, patient partners, decision makers, ethics committees to come together and work to find solutions that are much more efficient because we're still very much behind understanding what has happened in the last few months. And that seems to me an urgent situation that needs to be solved. We're still struggling at getting our research projects off the ground. And many of the struggles we have are a lot with privacy. And I understand why it's so important to protect privacy, but at the same time, there needs to be some sort of openness so that we can have access to data to make the correct diagnoses.
Yeah, and I think that's the ultimate, that's always been something we've struggled with in public health, right? The good of society against the protection of the individual. But I think at a certain point, the good of the society starts to hugely overlap with the good of the individuals. And we've seen this in the mask policies, and I love that video. We need more of them. It's I'm always a bit horrified when I go out and see how few people are wearing masks. Mm-hmm. So I think we are just about out of time. I think that was incredibly helpful. I wanted to, a few housekeeping items. The SPORE networks, a strategy for patient-oriented network, and our primary care network, which is a network of networks. Our main funder is the Canadian Institutes for Health Research, but all of our networks, including the Network Coordinating Office, have funding partners. So there's numerous people that contribute time and energy and funds into making this possible. So I do want to thank them. I know that Réseau 1 has put a lot of seed pilot project in. You've just heard the results of that. That's what I consider a very healthy return on investment for the network, and some of the people had funding partners for those projects. So thank you to all of our funders who make this possible, and how quickly these projects got funded. So that also meant there were a lot of reviewers who contributed time in the middle of the craziness that was our lives during COVID. I'd also like to thank Jamie Demour, who is the coordinator for the Network Coordinating Office, as well as Daniel Schrimmer, who works with Réseau 1. She is taking a very well-deserved vacation this week, but she certainly made sure that we were all had our ducks in order before she went. And also our summer intern, Stephanie Hindle, who has been making sure everything gets posted and the flyers sent out. Later this week, you will be getting by email all of those who have registered a survey. Please do complete it. We will be developing some fall webinars with similar key interest topics. We have many projects that are multi-province, with including territories, with results that are incoming about primary care that'll be very relevant. Including some of our patient partnered activities. So you will be getting those, and you have in the chat, I encourage you to visit the SPORE PICN website. So it's spore-PIHCIN.com, where this webinar, along with the original 6, have been posted for you to review or to recommend others. So a lot of times people like to have them posted because then they can recommend their funding partners, can see what they're doing, as well as other interested stakeholders. So I want to thank a fantastic group of panelists. That was a great oversight. It was like a world cafe of COVID-19 primary care research. Very much appreciate, c'est très apprécié. I appreciate the efforts to make this as bilingual as possible and accessible as possible. Mais merci beaucoup pour toutes les personnes qui a fait des diapos en anglais ou qui a parlé en anglais quand même, qui a répondu à toutes les questions ici. So thank you, everybody. Enjoy the remaining days of summer, and I hope to see you at our webinars in the fall. Bye-bye.